Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having on the podcast Dr. Prof Banerjee from the Royal Marsden in London, and also Dr. Rachel Grisham from the Memorial Sloan Kettering Cancer Center. And today we're going to talk about the RAMP 201 trial, efficacy and safety of Avutometinib and Defactinib in recurrent low-grade serous ovarian cancer, primary analysis of NGOT OV60 GOG 3052 RAMP 201. This is a recent publication in the Journal of Clinical Oncology. Susie, Rachel, thank you so much for accepting our invitation. Congratulations on the publication of RAMP 201. We're looking forward to discussing this important study. So thank you so much once again for your time.
Thank you so much for having us. We're excited to talk to you today.
Excellent. So, Rachel, I'll start with you. I wanted to start by discussing how frequent are recurrences in the setting of low-grade ovarian cancer after completion of primary treatment, and also what is the expected response to standard chemotherapy in this recurrent setting?
Thanks, Pedro. So yeah, unfortunately, similar to high-grade serous ovarian cancer, the vast majority of patients diagnosed with low-grade serous ovarian cancer will have advanced stage disease at time of diagnosis, and more than 70% of those patients will ultimately recur and have a chronic disease that unfortunately they ultimately pass from. And this is especially concerning because we think about low-grade serous ovarian cancer as being a rather chemo-resistant disease. So in the recurrent setting, response rates to standard of care therapies like chemotherapy and endocrine therapy generally have response rates less than 15%. Now, more recently, the use of single-agent MEK inhibitors such as trametinib and binimetinib have shown more promising response rates ranging from 16 to 26%, but definitely still a need for more efficacious therapies for treatment of this disease.
So with that, then I'll turn over to Susie, and just wanted to have you go over what are the agents that were studied here, and what was the data on efficacy that led to this study?
Well, thanks, Pedro. Thanks for inviting me. I think the last time I did a podcast with you was actually following Solo 1, which is in high-grade serous ovarian cancer. So it's really exciting to be talking about low-grade serous ovarian cancer here. These are completely new drugs. So Avutometinib and Defactinib, they're oral drugs targeting pathways that we know are relevant to low-grade serous ovarian cancer. Avutometinib is a first-in-class oral RAF/MEK clamp. So this inhibits the MEK kinase activity, but it also helps block a compensatory reactivation of MEK by upstream RAF. And Defactinib is a selective inhibitor of a molecule called focal adhesion kinase. And this molecule's involved in the integrin pathways, and signaling of this and targeting this has been shown to mediate resistance to multiple anti-cancer agents. So it's actually preclinical work that the combinations could be beneficial, for example, in models such as melanoma, but also low-grade serous ovarian cancer. So going on from there and the preliminary data, my colleagues at the Institute of Cancer Research in London hypothesized that inhibiting the MAP kinase pathway and the FAK pathway with these two drugs could cause some responses in MAP kinase driven solid tumors, and that includes low-grade serous ovarian cancer. So this led to the academic sponsored UK study FRAME. It was a phase 1 study, and it was led by the Institute of Cancer Research, and I was really pleased to present those results in ESMO a few years ago, and we recently published the results in Nature Medicine in June this year. So what we showed, if I focus on the low-grade serous cohort, there's about 26 patients evaluable for efficacy, and that was in the escalation and the expansion cohorts. And we saw that the overall response rate was 42% overall, irrespective of KRAS mutation status, and the Progression-free survival was around 20 months in this small study. If we looked more closely at the KRAS mutated recurrent low-grade serous ovarian cancer patients, the response rate was higher, it was 58%, and the PFS was 30 months. Lower number of patients, that's 12 patients with the KRAS mutation, but a really good signal. And importantly, with toxicities, only 4% in this phase 1 withdrew because of toxicities, and that was actually a grade 3 skin toxicity. So putting into context what Rachel's just said, these results were favorable compared to standard of care and other MEK inhibitor studies, and that led to the FDA breakthrough designation and the RAMP 201 registration-directed study, NGOT-OV60 GOG3052. So true collaboration and really exciting preclinical and phase 1 data leading to this.
Great. Thank you so much. And thank you for actually outlining the journey of how we got to this study. So Rachel, I'll turn to you with regards to this particular study now. The methodology. What were the inclusion criteria? Understanding that it's a 4-part multi-center, parallel, randomized, open label trial. Tell us about these parts and the details on treatment.
Thank you. Yes. So I think this study was actually designed in a really innovative way to be able to answer multiple different questions through the course of one study, which is so important in patients with a rare disease to be able to optimize the number of questions answered in this one pivotal study. And so this study enrolled patients with recurrent low-grade serous ovarian cancer who had measurable disease by RECIST 1.1 criteria. And these patients needed to have received at least one prior line of platinum-based chemotherapy. But after that, they could have received unlimited additional lines of therapy. And that could have also included treatment with a prior MEK inhibitor. So about a quarter of the patients that went on to this study had received a prior MEK inhibitor with their prior lines of therapy before study entry. Now, before patients went on to study, we also had to know if they had a KRAS mutation or not. So they had to have had tumor testing done to see if they had a somatic KRAS mutation. Patients did not need to have a KRAS mutation in order to go on to the study. It was a stratification factor, but we just needed to know what their status was before they enrolled. So in the initial 2 cohorts of the study, parts A and parts B, patients were initially randomized to treatment either with avutometinib as a single agent at a higher dose, 4 milligrams twice a week by mouth, 3 weeks on and 1 week off, or the combination of avutometinib with defactinib at the standard dosing, which is 3.2 milligrams of avutometinib by mouth twice a week, with defactinib 200 milligrams by mouth twice a day, both given 3 weeks on, 1 week off. And so this was to see what the relative benefit was of the combination therapy versus avutometinib alone. And based on the results of parts A and B, it was found that the combination had a higher response rate and similar toxicity to the single agent avutometinib. So therefore, the combination of avutometinib and defactinib was chosen as the go-forward regimen. And then in part C of the study, additional patients were enrolled to that combination regimen so that we could obtain additional information about the relative efficacy, activity, and toxicity of this combination in patients with recurrent disease. And then the final cohort, cohort D, was a dose optimization cohort. So this actually looked at a lower dose of avutometinib, 1.6 milligrams, in combination with the standard dose of defactinib, in order to see if a lower dose of avutometinib could be just as efficacious. Now that dose optimization cohort found that that lower dose was suboptimal, indicating that the standard dosing of avutometinib and defactinib was the best regimen to continue forward with.
What a great design, and thank you so much for providing that outline. And of course, obviously, I think it lends itself to, as you said, perfectly for these very rare tumors. So with that then, Susie, what were the endpoints of the study? And also, particularly in this patient population, how were the patients assessed for response?
Thanks, Pedro. So as Rachel explained, the aim of this was really to look at activity and also safety. So the primary endpoint was objective response rate, and this was according to RECIST version 1.1, and this was assessed by blinded independent central review, so BICR analysis. There were secondary endpoints, really important from a clinical and perspective, duration of response, as well as overall response assessed by investigator, progression-free survival, overall survival, and classic safety endpoints, as well as looking at pharmacokinetics.
So now on to the results. 115 patients, I believe, went on to the go forward combination regimen. What are some of the highlights that you want to point out with regards to this study?
Yeah, thanks, Pedro. So that's the exciting thing, right? The results. So we were really impressed with the results of the RAMP 201 study that showed an overall response rate of 31% for the total population of patients treated with this combination regimen at the standard dosing. And so, as Susana said, the primary objective here was to look at the observed confirmed response rate. And then it was also looked at in those patients specifically with a KRAS mutation or without. So for those patients without a KRAS mutation, the response rate was 17%. And for those patients with the KRAS mutation, the response rate was 44%. And it's not too surprising that we saw a higher response rate in those patients with a KRAS mutation, because we do know that KRAS is a prognostic indicator, and that patients with low-grade serous ovarian cancer that have a KRAS mutation generally do have higher response rates, both to standard of care therapy and targeted therapies. But outside of that response rate, I think it's also really important to note that patients remained on these treatments for a long period of time. So for those patients that were KRAS wild type, the median progression-free survival was 12.8 months. And for those patients with the KRAS mutation, the median progression-free survival was 22 months. And in particular, those patients that responded had really meaningful responses. So the median duration of response was more than 31 months. So I think the main takeaways here are not only are these active drugs that lead to meaningful response rates, they're also drugs that patients can continue on for really long periods of time and have meaningful, durable responses too.
Yeah, and absolutely. As you mentioned, really numbers to highlight: 44% responses in KRAS mutated patients. Really important findings, and progression-free survival to 22 months. So now let's get on to some of the questions. As you know, we usually have questions from our fellows in the journal. This first question comes from Filippo Capomacchia in Candiolo, Italy. And he's asking, which molecular mechanism underlie this synergy of combined MEK and FAK inhibition in recurrent low-grade serous ovarian cancer?
Thanks, Pedro. So I think this is a really important question, and we're learning a lot more about the mechanisms across MAP kinase-driven tumors. But the real premise, in particular, as this is a RAF-MEK inhibitor, is that when you inhibit MEK, you can get compensatory activation of this FAK signaling. And so if you block two pathways simultaneously, the hope and what we then showed clinically in RAMP 201 was that this could help overcome some of the potential shortcomings of single agent MEK inhibitors in terms of resistance, leading to more enhanced tumor suppression, potentially reduced metastases. There are preclinical models, not only low-grade serous ovarian cancer, but other cancers such as melanoma that have shown this. But really, we need to look further in these clinical trials and in real-world practice through biopsies to understand more about the resistance mechanisms and how these drugs actually work together. There have been studies of single agents, but actually it's this combination that seems to, and also the dosing, I haven't really mentioned that, but this intermittent dosing and the schedule, I think is a real plus for these agents together, because toxicities have been a limiting factor exploring these pathways previously.
Yeah. So now, Rachel, Sofia Bigardi from Padova University Hospital in Italy, she's asking, as you mentioned, the combination of these two drugs showed a median duration of response, impressive 31 months. So she's asking, how do these results compare with other currently available therapies for recurrent low-grade serous ovarian cancer?
Yes, and of course we can't do direct trial-to-trial cross comparisons because these are different patient populations, but it's really hard not to do that, right? Because we want to look at how do these results measure up to what we've seen in prior prospective clinical trials for patients with low-grade serous ovarian cancer. And so really the two best studies for us to compare to are the only other phase 3 studies that have been done in patients with recurrent low-grade serous ovarian cancer. So the GOG 281 study, which was a phase 2/3 study for patients with recurrent measurable low-grade serous ovarian cancer. And that study randomized patients to treatment with a single agent MEK inhibitor, trametinib, or physician's choice of chemotherapy or endocrine therapy. And then the other phase 3 study done in recurrent low-grade serous ovarian cancer, which was the MILO study. And that study similarly enrolled patients with recurrent low-grade serous ovarian cancer, measurable disease, and randomized patients to treatment with either the single-agent MEK inhibitor binimetinib or physician's choice of chemotherapy. So all three studies, while different and had different inclusion and exclusion criteria, they were similar patient populations. So if we look first at GOG 281, I think it is important to note that in that study, the primary assessment of progression-free survival and response rate was assessed by the investigators. So there was not blinded independent central review for that study. And I think it is important to note that the efficacy results for both the RAMP 201 study and the MILO study were via a BICR, blinded independent central review. As we know, we oftentimes don't have complete concordance between investigator assessments and BICR assessments. But that being said, in the GOG 281 study, the response rate to standard of care chemotherapy or endocrine therapy was 6%, with the highest response rate seen for those patients who were treated with letrozole. Those patients had a 14% response rate. But from there, it all went down. So 9% to weekly paclitaxel, 3% to liposomal doxorubicin, and 0% response rate to tamoxifen or topotecan. So when we look at those numbers versus that 31% response rate to avutometinib and defactinib, I think we see a clear difference there. Now, the response rate to trametinib in that study was 26%. But I think it's also important for us to look at how long patients remained on these treatments. So in GOG 281, they did a similar analysis to what we did in the RAMP 201 study, where they specifically looked at those patients who had a KRAS, BRAF, or NRAS mutation and looked at them as a group to see what their median progression-free survival was. And in the RAMP 201 study, we specifically looked at the patients with a KRAS mutation. So in the RAMP 201 study, for those patients treated with avutometinib and defactinib with a KRAS mutation, the median progression-free survival was 22 months. And in the GOG 281 study, for those patients with a KRAS, BRAF, or NRAS mutation who were treated with trametinib, the median PFS was 13.2 months. And the median duration of response for those patients treated with trametinib was 13.6 months, versus that 31-month duration of response for avutometinib and defactinib. And so while we can't compare these results, one-to-one, I think it is really meaningful how long patients were able to remain on treatment with avutometinib and defactinib versus how long they were able to remain on treatment with trametinib. And then when we look at the MILO study, which did have blinded independent central review, similar to the RAMP 201 study, there, the response rate to treatment with binimetinib was 16% versus the 31% that we see with avutometinib and defactinib. And the median duration of response to binimetinib was 8.1 months. So again, really the longest duration of response we're seeing, the longest PFS that we're seeing is really for those patients that were treated with avutometinib and defactinib in terms of prospective data that we have thus far.
Yeah, no, impressive results, and thank you for that cross-trial comparison that we obviously always appreciate. So this next question comes from Helena Obermeyer in Sydney, Australia, and she's interested in how prior therapy impacts efficacy. So her question is, many patients in your study had extensive prior treatment, including MEK inhibitors and bevacizumab, and those patients seem to have a lower response rate. Why do you think these prior therapies might influence the efficacy or tolerability of this combination, and how should that inform patient selection?
Thanks for that question. So I think, it's really important to say, having heard what Rachel just presented in terms of our standard of care options and single agent MEK inhibitor options, that actually with the lower response rates with prior MEK inhibitors, number of lines of therapy and bevacizumab, there's still notable response rates. For example, with the prior MEK inhibitor, the response rate was 24%, no prior MEK inhibitor, 33%. And even with prior Bev, 20% response rate and more than 3 prior regimens, 24%. So putting that into context with what we have already, these are still highly relevant response rates. So in terms of reasons for the differences, this was a planned subgroup analysis. I think it really is a reflection of how heavily pre-treated patients are. It'd be interesting to look at when patients actually got the bevacizumab, if it was in the first line setting or in relapsed disease. I can't think on the top of my head of a mechanism of why the use of bevacizumab would per se affect response rate. So I think it's a reflection of other parameters that go hand in hand, like number of lines of therapy. And, just to point out again, the response rates that were in the other prospective clinical trials of MEK inhibitors were in patients that were MEK inhibitor treatment naive. And so in this study, and that's what's so amazing to have seen, firsthand treating patients, that patients may have progressed on a prior MEK inhibitor and then gone into RAMP 201 and derived benefit with this combination. So I certainly think it's a bit too early at this stage to inform patient selection. That's where we really need to await the results of the randomized phase 3 study, RAMP 301, to glean more information in a randomized way, looking at the prior lines of treatment.
Great. Natalia Tejeda from the hospital clinic in Barcelona. She's interested in the amount of tumor you start off with. She says, did you explore whether initial tumor burden, volume of measurable disease impacted the response to this combination? Do you believe baseline tumor burden could play a role in identifying patients most likely to benefit from this treatment?
Yeah, I think that's an interesting question. So all patients that entered onto this study had measurable disease, but we didn't specifically look at a criteria for tumor volume and correlating with response rate. But I think that is something that could potentially be looked at in the future. Circulating tumor DNA was collected during this study and correlated with response rate. And I think that's a more in-depth conversation, but I think one of the big takeaways actually from the circulating tumor DNA information was that low-grade serous ovarian cancer tends to be a low shedder, and that it's not a reliable biomarker for low-grade serous ovarian cancer. So maybe I'm answering a different answer to this question, but it is something that I wanted to get across, is that I don't think we can rely on circulating tumor DNA as being a reliable marker for disease burden or disease response in patients with low-grade serous ovarian cancer. And I think we need more information on that as we go forward. But I think there was some really important insights about that gained from this study, and I think that we'll continue to learn more about that in the coming years.
Yeah, well, thank you so much for offering the information about ctDNA. As you mentioned, and I was like, I can't believe we don't have a question about ctDNA.
Yeah, I know, I was surprised there wasn't one. Yeah.
So thank you. This next question comes from Elena Obermeyer again in Australia, and she's asking about the patient selection based on mutation. So the overall response rate was higher in KRAS mutated subgroup compared to the KRAS wild type. You think that this regimen should be reserved for KRAS mutated patients only? Do you think there may be other factors besides KRAS that predicts response?
Right, so based on the current FDA accelerated approval, Avutometinib and Defactinib is for patients with KRAS mutations. It's restricted to that group in recurrent low-grade serous ovarian cancer. But the activity of KRAS wild type, I feel, is also very notable. So just pulling out some of the aspects that Rachel mentioned before, if we look specifically at the KRAS wild type in RAMP 201, so 52 patients KRAS wild type, the response rate was 17%, PFS 13 months. Let's take trametinib in GOG-281. The response rate with trametinib in the wild-type patients was only 8%, and there was 48 patients there. It's a similar number of patients. So with the combination of avutometinib and defactinib, there's more than double the response rate, and the progression-free survival is also notably longer. And if we look at standard of care treatment, response rate in the KRAS wild type was 7%. So I think, it's too early, and as we've talked about already, not comparing trials, but looking at what's available to our patients. We really need the results of our phase 3 RAMP 301 trial, which specifically looks at KRAS wild type and mutated groups of patients in a randomized setting against standard of care chemotherapy and endocrine therapy. And that's where we can really see the predictive element of relevance of the KRAS mutation and also the KRAS wild type population. And let's not forget that there are other relevant mutations beyond KRAS in the MAP kinase pathway. So it's important that we do report, and we will be looking at this in terms of BRAF mutations, NRAS mutations, which in this study would fall in the KRAS wild type group.
Yeah, excellent points. And of course, now we get into the adverse events. And Frederica Stroich from Heidelberg Hospital in Germany, she's asking, many patients experience those interruptions due to adverse events. Was there a specific timing of these interruptions? Did most doses hold occur early during the treatment, or was there an improvement over time?
Yeah, and I think it's so important to talk about the toxicity of these drugs because we need drugs that are efficacious but also tolerable, especially if patients are going to be treated with these for months or even years. And I think actually overall these drugs were quite tolerable. So 56% of patients did experience a dose hold during the course of the study. And this was most commonly for asymptomatic elevation in blood CPK or for elevated bilirubin, so for laboratory abnormalities that then generally normalized with dose hold. But ultimately, only 10% of patients experienced a dose reduction. And this is actually quite low for patients that were on treatment for a long period of time. The relative dose intensity for avutometinib was 0.84 and 0.77 for defactinib. So if we look at GOG-281, where patients were treated with single-agent trametinib, there 70% of patients had a dose reduction. So 70% of patients dose reduced with single-agent trametinib, only 10% of patients dose reduced with avutometinib and defactinib. In the MILO study, the rate of dose reductions for binimetinib was not reported, but the relative dose intensity for binimetinib was 0.68. So you look at that versus 0.84 for avutometinib in this study. So I'd say overall, actually, patients were able to tolerate the avutometinib and defactinib quite well, and it was quite rare that patients had to dose reduce or discontinue treatment due to toxicity. And I think it's reassuring that most of these dose holds were just for laboratory abnormalities that then resolved with the dose hold.
Yeah, so excellent point. And as a follow-up to that, Luisa Prope from Munster, Germany, she's asking, what strategies should we use when those patients develop toxicity in order to still maintain quality of life for those patients?
So it's really key that the toxicity profile, as Rachel's just summarized, looks encouraging compared to and in line with other MEK inhibitors in terms of discontinuation. But when we move into the real world, it's not so rigorous as in a clinical trial. So it's really important that the main strategy is education. Education of the clinical teams, the oncology teams prescribing this and managing patients, and education of patients so they know what to report and when to report and who to report to. Because it's really clear that with dose modifications, it's possible to continue treatment because the discontinuation rate was low, was relatively low. For example, management of rashes, prophylactic medication, also knowing when is the peak time of this happening and the duration. Also other aspects like diarrhea, fatigue, nausea, which are generally grade 1 to 2. And it's really about supporting patients actively rather than waiting till this becomes severe in order to manage this. So similar principles with the raft of new drugs that are entering our clinical arena in gynecological cancers, and also thinking of other class effects of MEK inhibitors such as blurred vision, and also thinking rarer, but knowing about potential effects on left ventricular ejection fraction. So it's about thinking about toxicities that can occur early, but as some patients are on this for quite some time, given the progression-free survival, it's about being alert and aware of some side effects that may occur later on.
Yeah. And one additional question on the same topic, Frederica Storage is asking, did you collect patient-reported outcomes in this study? And can you share if patient-reported improvement of their quality of life over the course of treatment?
So in this study, the RAMP 201 study, patient-reported quality of life assessments were not collected. But as Susana mentioned, there's an ongoing confirmatory phase 3 study, RAMP 301, which is almost fully accrued. And so in that study, patients are randomized from Avutometinib and Defactinib to standard of care therapy, and quality of life assessments are being collected in that study. So it'll be really interesting in that study for us to compare patients' quality of life both over time on these treatments and in comparison to standard of care therapy.
Yeah. So then now onto the topic of treatment beyond this. So Natalia Tejeda is asking, do you have any information on whether subsequent treatments were administered to these patients? Were any patients re-challenged with MEK inhibitors at any point? How did they respond to other therapies after this?
So that's really important, especially in clinical practice now. So as far as I'm aware, I don't think we collected information in RAMP 201 with regards to subsequent treatments, although we did look at the responses and the details of prior treatments in order to see whether, in this single arm phase 2, effectively of the go forward regimen, whether the response rates were improved compared to prior treatments. The other challenge in answering that question is, as you know, the licenses of the MEK inhibitors, the use, I guess it's an NCCN guidelines, and also in the UK, we can use trametinib, but it needs to be in MEK naive patients. So in standard of care real world practice, we're unable to use a MEK inhibitor post Avutometinib and Defactinib. It'll be interesting what happens in the real world across practices. So I'm not able to formally address that question, but I'm sure we'll hear of some case reports. But equally, remember Arm D of the trial design that Rachel mentioned, which was actually a lower dose and then going up to a higher dose for patients that actually progressed on the lower dose. And I've actually got one of my patients in that situation right now. And I'm encouraged by what I'm seeing with the standard now dose of Avutometinib and Defactinib rather than lower dose in that individual who's already had effectively MEK inhibitors. So I think that we're going to learn a lot more from what's happening in real world practice. And Rachel, I'm trying to think, in RAMP 301, are we collecting subsequent treatments? And if not, perhaps we should.
Yeah, it'd be challenging to get the response rates on subsequent therapies. So, but
so
we
Rachel,
can do case reports.
Of course, obviously, when we're seeing such favorable results in this setting, the next question seems fairly obvious to ask. Sofia Bigardi is asking, do you think this combination can also play a role in the frontline setting or in a combination with other targeted agents or immunotherapy in the future?
Yes, it's so important. I mean, of course, we routinely look at our new drugs in the recurrent setting, but as soon as they look promising, we really should be trying to move them forward to the frontline setting, because we really need to be giving our most active agents in the frontline setting, because that is our best chance for improving overall survival and improving cure rate for our patients. So in hopes of that, we've opened a study called Chameleon at Memorial Sloan Kettering Cancer Center, and it's now also open at Emory as a secondary site, which treats patients who are with newly diagnosed low-grade serous ovarian cancer who are not amenable to primary debulking surgery due to extent of disease, or who've had an initial primary debulking which was suboptimal and have residual measurable disease. And so those patients are receiving frontline therapy with Avutometinib and Defactinib in combination with letrozole. And so interim results of that study have not yet been presented. But yes, I do think these drugs will move into the frontline setting in the future, yes.
Great name for that study, by the way, also. And then, of course, obviously, you mentioned endocrine therapy. So the next question from Marina Rosano in Milan, she's asking, given the efficacy of endocrine therapy being modest and low response rates with platinum-based chemotherapy, where do you see this combination fitting into how we currently traditionally have been treating patients?
So I think it's really exciting to put this into the context of other investigational agents in clinical trials and combinations. So I think where we stand now, this trial, RAMP 201 and also 301, is for patients that have had prior platinum-based chemotherapy. So I'm very excited about the study that Rachel just mentioned in the frontline setting. But as it stands today, I would be placing Avutometinib and Defactinib in patients that have had prior platinum-based chemotherapy. In terms of which line, my preference here in particular, we're talking about the accelerated approval indication, which is in KRAS mutated low-grade serous ovarian cancer. I would give this combination earlier on, so not for later lines. For a variety of reasons, I'd like to give my most active, most promising treatment earlier on for my patients. Also taking into consideration what we've talked about, that there's some signals suggesting that the likelihood of response is lower with heavily pre-treated patients, so I'd rather give this earlier on. And also thinking about the patients themselves, their quality of life, toxicities. With low-grade serous ovarian cancer, we know that sadly, bowel obstruction, for example, can be a real problem. And I'd rather give this oral agent earlier on and reserve endocrine therapy. For example, the GOG 3026 study of ribociclib, the CDK4/6 inhibitor with an aromatase inhibitor, letrozole. At the initial presentation, the response rate was around 23%. So putting that into context, I think that this is yet another option, an endocrine combination, but I would put this as the data stands today as the Avutometinib and Defactinib coming earlier on, and the endocrine therapy balancing toxicities and monitoring as a later line.
Yeah. So just a couple more questions, and I think this next question is kind of like crystal ball, but this question is from several of our fellows, and it asks, given the ongoing RAMP 301 trial, evaluating this combination versus investigator's choice in this recurrent low-grade setting, what differences are you expecting in terms of efficacy, in terms of tolerability, when you look at the potential results of the RAMP 301?
Yeah, so we're super excited to see what these results are in the near future. But so the primary objective of the RAMP 301 randomized phase 3 study is to look at progression-free survival for these patients treated with avutometinib and defactinib versus standard of care therapy. And there's a hierarchical design where we first look at those patients that have a KRAS mutation and then look at the overall population. And so I think that there's really three main things that we hope to gain from this study. So number one, looking at those patients with a KRAS mutation. In the United States, we already have an accelerated approval of these drugs specifically for those patients, but we need this confirmatory phase 3 study in order to achieve that full approval. And so, based on what we've seen, I feel pretty confident in that result. But number one, we've got to show that these drugs are better in KRAS mutant patients than in those than standard of care therapy. And then number two, the big question is the KRAS wild type patients, because we know that these drugs do have activity in KRAS wild type patients. And as Susana mentioned, our standard of care therapies and single agent MEK inhibitors, they have very low response rates in these patients with wild type disease. And so I think there's a good chance that avutometinib and defactinib are the most active agents that we have for these patients with KRAS wild type low-grade serous ovarian cancer. But the only way to know will be to see the results of this randomized phase 3 study. So I hope that gives us the information that we need in order to potentially be able to expand the indication of these drugs to KRAS wild type patients as well. And then finally, that question about toxicity. And so I think actually over the long term, we may find that treatment with avutometinib and defactinib is better tolerated than standard of care therapy. But the best way to assess this is to have objective data about rates of dose discontinuation, dose reductions, and these quality of life outcomes that your fellows mentioned are so important for us to assess in our populations. And so luckily in the near future, we'll have the answers to these questions.
Fantastic. So as a new tradition in the podcast, we now have as the last question, a question generated when we fed your manuscript to AI. And actually, I see that you both actually predicted somewhat this question because I think you've alluded to it already. But the question from AI is, the study highlights striking differences in outcomes between KRAS mutated and wild type patients, 44% versus 17%. Should this drug combination now truly be considered a standard of care for all patients with recurrent low-grade serous ovarian cancer, or really just focus on KRAS mutated patients?
Well, hopefully the AI will listen to this podcast and then actually understand that it's not striking differences, and will rephrase the question afterwards as we've explained. So hopefully that will be the case. But in short, this is evolving, just like Rachel said. So as it stands today, the current accelerated approval is the KRAS mutated group. But as Rachel said, we're so glad, thanks to global collaborations, that RAMP 301 is practically finished recruitment, and we will get the results which hopefully will support the expansion of all women with low-grade serous ovarian cancer. I think that based on what we've said earlier in the podcast, based on looking at prior prospective trials and what we know, it certainly is a real potential, and we just can't wait for the results of RAMP 301.
You heard it here, Dr. Banerjee standing up to AI. Thank you so much to both of you. Always such a pleasure. Learned so much from speaking with both of you. Congratulations to you and to all of the co-authors of this project. And then again, we're super excited to hear about RAMP 301. So hopefully there will be another podcast on RAMP 301 soon. So thank you again. And I really do also want to thank you for everything that you both have contributed and continue to contribute to the field of gynecologic oncology. Very, very impressive.
Thank you for inviting us.
Thank you so much.